Assalamu alaikum. Welcome to today's Cataract Surgery Insight into a sclerotic type of hypermature cataract with dense anterior capsular fibrosis. You can see clearly the fibrosis in the central portion of the lens. Now I'm staining the anterior capsule with tryphen blue. Now wash out the blue rays with BSS. Now form the AC with dispersive and cohesive OVD. Now you can clearly see the wrinkling of the anterior capsule due to the fibrosis. With the help of the cystosome, I initiated the rhexis but was finding difficulties in raising the flap due to the fibrosis. And also the anterior capsule was friable. It was getting torn at multiple sites. So I decided to bluntly dissect the fibrosis from the anterior capsule with the spatula but failed, and it was also causing stress on the zonule. So I stopped. In these cases, it is best to use capsular rhexis forceps to do the rhexis. As I started pulling the flap, you can see the zonular stress, and the rhexis was not following the forceps pull, but it changes its direction. Then I decide to pull the flap downwards beyond the fibrosis to the healthy anterior capsule. While doing this maneuver, part of the flap tore, but part of it remained. I grabbed hold of that flap and pulled it down to the healthy anterior capsule. Now grab hold of the fibrotic tissue along with the rhexis flap for better control while making the rhexis. Make the rhexis go beyond the fibrosis by involving the healthy anterior capsule. Thereby, you will avoid the resistance from the fibrosis and you will be able to create a well-controlled continuous curvilinear capsular rhexis. See, I have created a beautiful continuous curvilinear capsular rhexis. Now I have placed the anterior capsule on the cornea and you can see the fibrotic tissue on the anterior capsule. Now perform hydrodissection to mobilize the nucleus from the capsular attachment. Refill the anterior chamber with OVD and make the two side ports with a 1.1 mm anterior blade. Again refill the anterior chamber with dispersive OVD and cohesive OVD to form a soft cell technique. Now rotate the nucleus with the help of the Sinski. Yes, it is rotating freely due to a successful hydrodissection. Now do a little bit of prephaco and remove the superficial cortex and the epinucleus. Now sculpt out a central pit in the nucleus, which will help me in performing chop in later stage. In this type of method of phacoemulsification is called modified chop. In modified chop, we make a central crater of 2/3 depth of the nucleus. Then we perform either vertical chop or horizontal chop. This crater will provide easy access to the endonucleus when I am bearing the phaco tip before I perform the chop. By bearing the phaco tip in the endonucleus, central portion of the endonucleus, you will have a great holding force and you will have a good chop and the pieces will separate properly. Now I perform the vertical chop. Now I'm separating the two pieces, but there is a thick leathery posterior plate which refuses to give way. Now I decide to vacuum emulsify this piece. Yes, a small triangular wedge has been vacuum emulsified. Now I perform the chop maneuver in the other portion, but there was a less uh, nuclear piece to hold, so I change position. Now I do chop in this part. Still there is attachment at the posterior plate which refuses to separate, so I keep rotating and continue with my chop maneuver, but still there is a central portion, it is attached due to the stubborn leathery posterior plate. Again I perform chop, but because the holding is not good, it went away. By mistake I was performing chop mode in quadrant mode, which had torsional power setting. In chop you should use longitudinal energy because it will have greater holding during chopping. My chopping was not good because due to two factors, due to the lateral posterior plate and due to incorrect setting. I used torsion has less holding force, so chopping was not good. Now continue with vacuum emulsifying of this. Everything is attached to the posterior plate. Rotate and chip away at the attached nuclear pieces. In doing so, later you will be able to flip this nuclear piece and you will have access to the posterior plate. In this case, a little bit of chemosis occurred, so I cut the conjunctiva and removed the chemosis with the help of the cotton bud. Now with the help of the Sinski, flip the nuclear piece and bring the posterior plate anteriorly, and you will then phaco this posterior plate to release the chopped nuclear pieces. Now emulsify the chopped nuclear pieces. Now continue with the phaco emulsification. Now change your setting to epinucleus mode and change the Sinski to spatula. This spatula will guard the posterior capsule from the phaco tip, thereby protecting the posterior capsule from any form of PCT from occurring. Now perform viscofluid exchange before coming out. Now assess the posterior capsule for any evidence of PC rent. As there was no evidence of PC rent, I continue with cortical removal with the help of the bimanual IA handpiece. Now change hand and remove the cortex from the other side. You can clearly see in the posterior capsule there is area of fibrosis and calcification. I have refilled the anterior chamber with OVD. Now I am implanting the IOL in the PC bag. Now with the spatula dial the tailing haptic into the PC bag. Now the case is completed, only remaining part is removal of the OVD. Remove the OVD with the help of the bimanual IA handpiece. Don't forget to remove the OVD that is strapped behind the IOL by taking the irrigation handpiece behind the IOL and flushing the OVD from the posterior capsule to the anterior chamber where it can be easily aspirated by the aspiration handpiece. Now perform stromal hydration of the side port and main port, and the case is complete. Now give intracameral antibiotic and subconjunctival dexamethasone injection. Now truly the case is completed. Thank you my dear friend for following me in this surgical video. Hope this video was helpful in developing your surgical skills.